My job is, this morning is a pleasure to introduce Mr. Jim Chase, who I've been looking forward to hearing his presentation because he's been doing some very important work. As I listened to Dana, my friend in the academy, by the way, are there more lawyers here than there's supposed to be? Would you identify yourself? It's safe territory. Can we raise your hands? We've got two more, so this is up 3. Wonderful, we've made a record here. So this is a multidisciplinary group, and one of the objectives we have is communication among each other, which is why I asked them to raise their hands, because we want to share information and knowledge. As I listened to Dana, it made me think about the relevance of the work that Jim Chase is doing. He's president of Community Measurement Corporation, which he founded, a nonprofit corporation in Minnesota. And in the context of this discussion, it occurred to me that the law and the policy that Dana was talking about has been in a dilemma because we have been focused on explicit bias and colorblindness, and therefore the courts and the laws taken position that we shouldn't look at race, that there are good uses of race and there are bad uses of race, and some of those films that she showed, the old films, are the bad use of race, where you take race and you therefore use it to limit and control people. But then there are also good uses of race where one looks at what's happening and tries to determine whether or not you can do better, which is what Movement is Life is about, trying to deal with health disparities. And an interesting contrast is the gun lobby, if you're prohibited from collecting statistics, then of course you never know what's happening. And with race and ethnicity, if you don't collect the information, then you don't know what's happening, and therefore you can say everything must be fine. And underneath that then lies all of this implicit bias that continues to impact on people. Well, Jim Chase is a person who is engaged in work that allows us to look at the information, to be transparent. And he is a nationally recognized expert in measurement of patient outcomes, looking specifically at race, ethnicity, and I hope that you will get a chance to learn more about some of the studies. I've been reading them online. I want to say one more thing before you come up, Jim. He's one of the most confident and humble people that I've met. If you look online for his bio, you get about a paragraph where he says very little about himself and refers you to his work. I had to keep digging and digging. And finally, he said to me last night, just tell them I have 3 children and I pay their tuition, and I do it happily. I'm sure he used that when he was negotiating his contract with Verona. Please come up to the stage, Jim.
So glad to be able to be here with you today. This is really, I've already learned so much, and looking forward to our conversation over the next couple of days. Is this our, trying to think of how I move the slides, is that what this one? Oh, that's the pointer. Sorry, I should have checked. Oh, here it is. No? Is this it? Yeah. Perfect. So I thought I would start with just telling you elevator speech of what I do. You know, we all have to have the elevator speech to try to explain to people outside of the industry what you do. And I'll tell the story about my daughter, who's now a senior in college. It's hard to think back 12 years ago when I started this work. She was in grade school. And I had, she knew what her mom did. She was a lawyer, so she kind of got that. And I had previously worked for the state of Minnesota. So she, at that time, sort of, oh, you work for Jesse Ventura, the wrestler. So she had in her mind what that would be like. I didn't really work with Jesse much, but, you know, in her mind, that's what I did. And I took this new job, and she said, Dad, you know, what do you do? And I said, well, I work for this group, and we take data from health plans and physicians, and we put it into quality measures so doctors can figure out how to get better care for their patients, and patients can figure out sort of, you know, what decisions they should make related to their care. And I thought that was really smart, and of course it went right over her head. She still had, Dad, what do you really do? So I was a little frustrated by that, and she was also... So my daughter's a really good speller, too. She was really into this. She's in grade school, and a couple of months later, they had something at school called Newsday Tuesday. And it was just when we came out with our first our first local report where we had all the measures that we were doing, and it kind of made news because it wasn't done anywhere else in the country at the time. And so it got on the front page of the paper. This is, remember, back in the days when people actually got the paper and read it at home. So they had this Newsday Tuesday, the kids could bring in an article, and that same day, on the front page of the paper, there was an article where Dad was quoted. And I was so excited, I took it to her and I said, "This is perfect. Says exactly what your dad does. Now you know what this will be." And she was very excited. Right at the breakfast table, she reads this long article. It's inside the fold as well, and gets to the bottom, and she looks up and said, "Dad, what's chlamydia?" And as a good dad, I said, "You need to talk to your mom about that." I did hear that she went into class and she explained her dad worked on some really important diseases, one of which is chlamydia, which is spelled with an H, because that was why I think she picked up that word through the mix. So this is just, again, our organization has been working to try to accelerate the improvement of health by getting information out to the public on what's happening with quality. And we moved from those first few measures we did 12 years ago now to quite a robust system where we have 71 measures. Just about every provider organization in the state provides us with some data. You can see there are 360 some sites of care, and I'm going to show you some of the data here in a little bit. I want to make sure that we cover a little bit about, I'm going to talk about what we're doing with measures, not all of them relate to the work that you're doing, but we do have a couple of new measures too that I want to share related to orthopedic surgery outcomes for knee and spine, and also doing a adolescent overweight counseling measure too. But most importantly, what I want to share with you is some of the data that we've been collecting related to equity and disparities and the impact that that's having around the community. And we'll share some of the activities that groups are using to try to improve their results and how it relates to what we heard a little bit about earlier today. And I also thought I'd start with this, that many of you may have read articles by Atul Gawande. This is one that came out right when we first got started that I think is very much a great story about why we're doing what we're doing. So Atul's put out many wonderful books now and articles, but this was one of the earlier ones. I think it's still posted on the New Yorker site where it was originally published. And he's a great storyteller. He tells this story of these cystic fibrosis clinics around the country. And what's unique about that is it's a very serious disease. It's relatively rare, so there aren't competing practices in every community. There's regional centers where people get referred. And so what was unique, though, about their system was for many years they had been collecting data and also publishing best practice guidelines about what should be done based on the literature about what would work well for patients. But not just having the guidelines, but actually then collecting data about outcomes for patients and sharing it amongst the group so people could learn from that. And it's interesting that he tells the story of the center that was in Cincinnati, where I grew up, actually. If you know that group there, the Children's Hospital, very well-renowned and a lot of great resources and so forth. But they were very frustrated when this data would come out that when they had everything they thought would work for this, that they had the right clinicians, they were following the guidelines, they were doing everything right, they were still middle of the pack in the results and couldn't figure that out. And so they went to the National Association and asked, could we go and visit, tell us who the number one group is. We want to go visit and find out what they're doing. And do you know what the answer was? No, we can't tell you that because, when you think this is, 15 years ago, one of the deals on collecting this data was we can't make it public because we're going to blind everything because people won't share the data if they're, they'd be worried it wouldn't be fair to the clinicians that work really hard on this. It wouldn't be fair to the patients to find out that their clinicians weren't, the very best in the country when they can't necessarily move to other communities. So he goes on to tell the story about that, how that had to change, and how the group actually realized that if they didn't share who was doing the best, they couldn't find out what the lessons would be learned about why there were differences, even though all the groups were following the same guidelines. And it turned out that the site that was doing some of the best, and you hear the story, wasn't about following the clinical guidelines, it was about the personal relationships with the patients and how that was working. But also talks about the real challenges we have in healthcare around needing to share and collect this information, but sometimes it's very hard and painful because then you have to admit, everybody wants to be the very best, and you're not always the very best at everything. But if you don't share that kind of information, you don't know what else you're missing in the outcomes. And that's been very much our theme of what we've been trying to do in Minnesota to get additional information. So let me tell you another one. I really like this. This is an article in the New England Journal of Medicine in 2013. It very much tells a story about what we've accomplished at a high level. This was a repeat. Some of you have probably heard before of Beth McGlynn's work around one of the real challenges in medicine is often when the research comes out and there's new data, things don't always happen for patients exactly the way we would like them to, and in fact, the data comes out often that about half the time patients get what they need. She did a big study with a whole bunch of conditions. This followed in the same realm and just looked at one particular thing, which is use of aspirin for people that have secondary prevention needs. In other words, people with diabetes or heart disease. The literature has been pretty strong around, if it's indicated for them, if they can get an aspirin use on a regular basis, that you're going to get much better outcomes. And so the article, the authors sort of bemoan the fact that this has been in the guidelines for a long time. It's got a great return on investment. It's very inexpensive. It has major impacts on the outcomes for patients. Very easy to do. And yet, they had to go back. It's not something you can get from claims data, so they had to actually go back in time and look up charts to see what had actually happened for patients. And the same thing happens. Around the country, only about half the time do patients get that ordered for them or have a discussion about it. What's interesting is in Minnesota, since this is one of the measures that we've been doing for several years, our rate, this slide is actually a little old, is now at 97%. And we know this because we're getting data from just about on every patient who's in practice with secondary prevention needs. And so it's an amazing thing, not just because of the impact of the change, but we know what the number is. We know what the number is because we're looking at it, and it's a sort of a cycle on itself. Because we're measuring this, it's been embedded in the systems within practices, and this is an easy one that gets done across. Now, a lot of our other measures, we see the same pattern in our other measures. By the way, when we first started, if we went back to 2007, we're a little bit higher than average. Our rate was about 70%. But over time, that sort of systematic approach to care has been able to increase that to the higher levels. And we see this same pattern in many of the things that we have been measuring. So this is our data on colorectal cancer screening, statewide trend. And so this is, as we've been reporting this, changed a little bit year by year. So in some ways, you could look at this and say, it's only 1 or 2% a year, that's really not a big thing. But we know, given from the literature, how important this is to get more people screened, that every year when we get 1% more, that's thousands of people more who are getting screened, and we know that can convert into, as this lists, several thousand life years saved every year in the state. And that kind of information gets practices really motivated in clinicians. We do hear a lot about the burden. You may in your own practices or hear from colleagues who work in healthcare that there is a great burden now of all this data that we're getting and the challenges. The key is, how do you do it on things that you can actually see the outcome over time and get people motivated about why it's important to pay attention to these? And again, I'm showing these because I will show you in a bit the disparities that we have on several of these measures as well. But what drives some of this difference? This is the variation by practice across the state. So each one of those, you can't see the little bars, this is a bar chart, of how often they get their patients who need screening screened for colorectal cancer. I don't know what the folks are doing up at the top there that are at 100%. You probably get tackled before you leave the office and say, if you haven't made your appointment, you need to do that. And we know at the far end of the scale on the right side, those that are very low, some of those practices are working with patients who are terminally ill or have other reasons why it's low. But for a lot of this, what we look at is it's that curve in the middle, when practices can see that other groups are doing something that they're not and actually getting better results for patients that drive some of this change that's been going on. The other thing I've been fascinated by is even though we see the rates statewide bump up just a little bit per year, it isn't because everybody works a little bit harder every year and everybody's rates go up a little bit. What you see is practices who intervene with something new in a given year will see a big increase. And quite frankly, what happens sometimes too is practices who have had a major change, may fall back a little bit. But overall, this has been a sort of progressive march for us to get better outcomes for patients across the state. We also do a diabetes composite measure. I won't go into the details of that, but it includes this aspirin measure that I mentioned
We've been doing this measure for 12 years in the state as well. And I've seen the same kind of pattern with the measure itself has changed, so don't pay attention to the numbers so much. But it has been a trend up year after year around more and more patients who are meeting the goals that clinicians have for them as far as outcomes, the things that really drive the differences. And I have some data from one of our health plans that matches this. As you see in the previous one how those results go up as far as the quality measures, you can see the morbidity and mortality related to this condition has been dropping in the state. And whether it's the eye problems or amputations and so forth. And again, this has been very motivating for people who, while we don't have a great published study around why this kind of data has driven these changes in Minnesota, people are seeing the impact that it has on their patients, and that's what gets us, I think, cooperation around collecting data and being able to publish it across the state. I think what's helped us to do this, setting this up in the sense of what we could do related to movement and equity, I think for this organization as well, I'd love to join in with that, is making sure you're not just putting data out for the sake of generating reports or publishing papers, but we tried to build it into the fabric of our community. We've got this robust set of measures. It's not just a set of quality measures, but we look at patient experience and cost of care. We very much try to get our measures to focus on outcomes, not just the process, so what really matters to patients, and I'll talk a little bit more about how that's been changing across the state. And very important, get them widely used. One of the most important things that I think we've accomplished is there used to be, and we still have this problem across the country, such a proliferation of measures and data collection that it starts to become a burden. And so we've tried wherever we can to align it across payers, get the same information used so it's got more impact and for the people who are collecting the data. And again, this being able to see significant improvements in the results has helped us be able to drive more change. And it gets used again across, we do a number of things to make sure the data is being used both by health plans, but also by the practices themselves wherever we can to drive additional change. And we found a really important component of this is actually making the data public. When we first started, as I mentioned, telling my daughter this story, a big piece that we thought wasn't just sharing it with clinicians, but getting patients to use it to make choices about where they would go. We do make it public, but our biggest driver, we think, is just because it's available to people. We actually have 100,000 website visits a year, mainly from the public that look at this information. We have very little evidence that they're actually changing where they go for care. It has a lot more to do with once this information is available, it often helps people understand what their clinicians are interested in, which helps them, but also motivates the practices because they know it's public. They can also see their friends and colleagues they went to school with and how they're performing on these measures. And this is just an example of how we display data on our site where you can actually look across by different practices and compare how they're doing on something like cost of care, but also their quality metrics as well. One of the things I was going to mention that we've moved towards, we started mostly with data that we were getting from health plans that was coming out of their administrative record and realized that wasn't nearly as powerful, especially with the clinicians as far as outcomes that patients were getting. Actually, for example, not just looking whether a diabetes test had been done, but was the blood sugar more in control, was the blood pressure more in control? And the way to get that was to actually get clinical data out of the medical record. So we developed a system where we could reach out and have practices across the state upload data to us. But that led us to an opportunity to actually look at something different. And we sort of backed into this by accident around getting patient-reported data. It was related to depression care in Minnesota. A lot of the primary care practices were very frustrated with outcomes for patients. The only measure that we had at the time was were they compliant with their depression medication. And what patients are really interested in are they getting better after 6 months or 12 months. And so we actually decided to use the tool, an assessment tool around the severity of depression. And we've collected that now for a number of years where you look at a patient when they first start in the practice and 6 or 12 months later, and are they actually getting better and reporting that. It's been very challenging for the groups because those numbers are quite low. As you know, depression is a really severe condition for many people. It's not as easy to just prescribe something and they're going to be better. But when you have that kind of information, you're actually hearing from the patients. It's been very motivating around what can you do differently, and practices have changed their approach on how they're working with depressed patients because this information is available and because they're seeing, again, better outcomes for patients if they make that investment. But that has led us, I think, which has been important, to be able to do some of the other measures that I'll talk about. Without that kind of ability to grab this data, we couldn't be able to get patient-reported information on their race and ethnicity, and what I hope will be in the future, other patient factors that will matter for their outcomes. So these are a number of different patient-reported outcomes that we're getting, and again, this race and ethnicity is really the newest focus that we have that we're quite excited about, and I'm going to show you some information on that here in a bit. But I thought you'd also be interested, we're one of the first places in the country that is looking at a total knee replacement measure. This is also one that doesn't look at, traditionally you might have looked at adverse surgical outcomes or infection rates and so forth. This is uses a tool called an Oxford Knee Score that looks at the patient-reported outcome of pain, functionality, and mobility, and reports it sort of before the surgery and then also 12 months after. And sorry for the terrible graphic here, but I just want to point out the importance to me of this isn't one, like we've done with many of our other measures, it has been sort of how well is the practice doing just in an outcome. What's promising, I think, about some of these patient-reported outcomes would be, this is a histogram, the distribution of how much improvement different patients get. And clinicians I know have been collecting this internally and using it for many years. But being able to start making this information more available to the public, you'll see here on this chart, there's a few patients, there's about 1% who don't get any improvement. In fact, they get a little bit worse in our data. And there's a set that actually gets some improvement, but it's not great. And then there's a lot of patients who are much, much better off, have a very high scale of improvement. But what's interesting is we should now be able to look at this by different patient factors and start to understand sort of who would be better or worse in that kind of outcome. We know one of the big ones that we make adjustments for in this is body mass index. How heavy is somebody when they go into this procedure? That will make a difference. And being able to communicate that to patients in effective ways, we hope is important by collecting this kind of data. And I won't go into the detail of this, but the thing I wanted to now share with you is our journey into now moving into looking at some of the disparities and equity issues. So this chart, you saw before that the diabetes results and how they've been improving across the state. So that's the upper red line, has been the statewide results. But we also wanted to take a look, we realized that after getting into this a few years, what was the impact for people in what we call public health care programs, Medicaid in Minnesota. It was our proxy to start with that we had some data around socioeconomic factors. And you can see, not surprisingly, this has been seen in other studies, significant gap in the outcomes for most of our measures related to people of lower incomes, their outcomes for the various things we look at. And that's very concerning. The good news is they have been increasing over time, but we haven't really been able to address the gap. The gap, if you see that, has gone down a little bit for some measures, but not that much for many of the chronic care conditions. So we're trying to motivate our practices in what can we do differently to try to address some of that. Here's an example of colorectal cancer screening. Again, we talked about how important this measure is, and for people of the public programs and Medicaid and so forth, the screening rate is 20% lower in the state than it is for people in the commercial products. And that was, again, has been a trend that we've tried to get practices, and I'll share some stories at the end about what groups are now doing to try to reduce those kind of differences that we're seeing to close the gap. But it's interesting, when you look at this, and one of our key messages has been, don't assume that everything is the same, because I have two examples where we've actually seen some closing of the gap, but there are examples where it kind of makes you go, about what some of the biases may be within practice. So this is one around, it's called pharyngitis. In other words, this is our kids who are getting antibiotics actually have a bacterial infection as opposed to just a virus. So, you're not supposed to give antibiotics if they're not necessary. And so this has been a sort of an overuse measure that we've had. And, unfortunately, it's not as high as you would like it to be. This shows the graph of between public programs and commercial. It's been pretty close over time. When we started, there was a small gap that it wasn't happening as much for people in public programs. Now public programs are actually higher. The only thing that makes me pause with that is this is one where it's actually something where people don't get something, right? Is it easier in a practice to say no to people in public programs to get antibiotics than it is the mother who's there with their kid from the suburbs who's complaining and is very activated with their patients? So we've been talking to groups about, we want to, again, watch, as we heard in the previous discussion, the biases that may occur. And you really see this with, again, back to my chlamydia story. This is our chlamydia measure. And look at between the higher part of the graph there that has been consistent throughout are people in public programs get screened much more often than the people who are not. Now, I think that's a positive thing in some level because we know the incidence rates are higher for people in public programs. So there's a natural reason for the bias that occurs from clinicians around they want to test the people who have the issue the most. On the other hand, it is recommended and in the guideline for everybody on this. So this is not just anybody being screened. These are people who are indicated for this screening. The guidelines should say it should happen, and there is a differential here that isn't what we would expect, but kind of proves the point around previously. We all come in with a set of biases. Sometimes they're helpful to get outcomes that we want. Sometimes they're not. And so how do we make sure that people are aware of that and we're trying to move? So in our reports, we get to happily say, oh, we've closed the gap on this one, but it's only because we've raised the rates for the commercial. We really haven't done much for the public programs. So this led us actually to looking at equity of care. And this has been an interesting process for us because of all the challenges we talked about, that we've been able to get practices across the state. We had to start with convincing everybody that we need to collect race and ethnicity, country of origin, and language data in a consistent way across the state. To be able to compare what the results are. So we started back in 2008 with that process and had to start with some education around this challenge you have of people saying, ooh, I'm not sure I want to ask about that because the best practice is you can't just assume what people are, you have to ask them. So I had an interesting experience with this as the measurement guy in the state. I'm always a little nervous going into practices because, as a patient, because people know that, especially where I go, they kind of know what I do. But it's fun because I get to see things we've implemented actually happening when I go in. And most recently this year, I went in and I had changed locations. So I went in to see at a new spot, and instead of having to fill out the form with things, the receptionist has said, oh, I got to update something. What's your race? And so I know this, and so I already knew. And she actually did the right thing, which is she also said, this is important for us to ask because we're using this information to try to improve care for patients. But I'm always a little nervous in the healthcare setting, and sometimes you just blurt out things that are ridiculous. So I said, I'm white, and I was born in Oklahoma. And I thought, oh man, why did I say that? And she looked at me like, there's no box for that, Mr. Chase. But it was because I think in my own head I was headed to the next question was going to be what's your country of origin, and somehow I got confused that Oklahoma is a country. I don't know. So, but it has been a big process, not of just being willing to share the results of this data, but getting people to actually collect it in a way that makes it useful. And it's something that we've learned in this, that these things don't happen overnight. This can take a while to get in place. We now have had 2 reports that we've been able to look at our quality measures by these different categories that we've been collecting related to race and ethnicity. And I'll show you the data. This is not surprising. We've known these disparities have existed from other studies in the state. But this is our colorectal cancer screening, I believe, measure. Of course, it's so small I can't see really closely. But yeah, cancer screening by race. And you actually look at that way in the second from the right column is African American or black. Greater disparity in Minnesota than just the socioeconomic when we look at public programs, more than 20%. And when you show this to practices, this really gets them motivated around not what they intend and not what they want to have happen in many places. So what can we do to try to make this change? And I'll just show you, we can now cut this data across, here's diabetes care. You see the same kind of pattern. And by ethnicity that we're seeing across the state with significantly lower outcomes for some of these hard chronic condition results than for certain populations and others. And, but what's been interesting as well is one of the great learnings of this is to not think about the populations, the more granular you get the data, of being white and everybody else, because the solutions are probably going to be much more nuanced and important than that. So you start to look at things like language preference. And it isn't that everybody with a different language preference is lower than English. There are some that actually are a little bit higher. And it's our new immigrants that are actually probably socioeconomically at a higher level, and they actually get better results. But then you can see at the bottom of that graph some real gaps that groups would like to try to address. And the same is true by country of origin. We have a lot of new immigrants in our state, and so this is very important to look at about what the differences are by different populations. And I just wanted to show this as well. This is a graph that just looks at just the African American results for colorectal cancer screening. What this is about and what the difference has been for us hasn't been, again, we've had studies in the past that show the disparity by community. It's having the community data allows us to drill down, and we actually now bravely are publishing, you can see on the right hand or the left hand side of the graph, by site of care. What is their outcome for these different populations? Not because we want to point fingers and say some groups are worse than others. In fact, at the bottom of the graph are some of our safety net providers who are really working hard to try to improve these results for patients. But it is important for people to see that there are differences, and what can we learn by what certain practitioners are doing that would get us better results and try to close some of these gaps. And this is just, we've also learned, you get different results by different areas of the state. This is looking at the optimal diabetes measure by race across the state. So you can see some of those variations. The thing that's very interesting, I didn't bring this slide, but when you look at Hispanic ethnicity, and you look at by region of the state, the inner city between Minneapolis and St. Paul, being on the St. Paul side, even though there isn't much of an economic difference, for some reason has much higher results than the Minneapolis side. We're very competitive there in the Twin Cities about things like that. But it's interesting, what can we learn about why that's occurring? And the difference of, for Hispanic ethnicity, people who are in the suburbs, not surprisingly in some ways, have much higher results. There's almost no gap there than people who are in the inner city or living in rural parts of Minnesota. And we can have hypotheses about why that is, but I think it's helpful to show groups and try to think about what can we do differently that would actually get results for patients in a different way. Just as an aside, I thought this is an interesting finding too. So we also do patient experience. This is, the letter you get a few days after you've been in the office that looks at several questions. And our data on this is an interesting factor why we try to do some of these balancing measures. The groups that have the highest outcome in quality generally have the lowest patient experience scores. And so African Americans, it's fascinating to me, while they have the worst outcomes in our state, give the highest scores to practices on patient experience. And my hypothesis has to do with people sometimes if they haven't had access to care as much as they would like, they're much more appreciative of being able to get care and for some of these questions than not. But it's also important to drill down into this by practice because it asks important things like, did you feel respected by staff? Did you get your questions answered? It's not just a satisfaction in the sense of did you like the parking, but there's some really important questions in this that need to be paired with, what are we getting as far as quality metrics as well as the patient experience. This is a weird graph. I'm sorry, this is fun for me. This is what I call a gravity well. So think of these as planets. And the reason why I want to show this is we were looking at having a statewide initiative around colorectal cancer screening. You may know there's a national effort to try to get the country to 80% of people screened by 2018, I think it is. And Minnesota's pretty close. And so we're trying to get some, what are our strategies to try to get there? But if you look at our data by population, the challenge becomes, white is the big one. That's Jupiter. It's the big gravity well in the middle of this. And some of our minority populations obviously are much smaller. So if you only have goals that are statewide and you push for those, you're naturally going to try to look at things that are worked for the entire population. And you miss these kind of gaps. And that's why I think it's very important for us to have a both-and strategy. We want to look at statewide measures and what happens with that, but you also have to focus on your gap populations and what can be done. It's interesting that some of our practices actually look at this in a different way. They say, you know, we've been doing this for a number of years. We've run out of tricks for what we do with our regular population, and everybody's now being measured by how much they improve in their contracts and so forth. They really want to do something to do a little better every year. The place to go is your gap populations, because there's not as many of them, but you may have some new things you can do, and if you can, there's a lot of room to improve. You're going to get a much better overall score if you can do that. So I hate to put it in this sort of context of these important things for people's lives, but what motivates people sometimes is, how are we doing on our scorecard, and how do we get involved in that, and if we can use that as a tool to drive change, I'm all for it. So. Some of the findings that we've had with this, again, there are significant inequities. We already knew that. The more important thing is that there's variation across practices in those inequities. And it's not just, again, driven by, we don't think, as we heard earlier, implicit racism on the practitioner's part. It's been just the opposite. There's a number of other things that are going on within the practice that are unintentional that we need to expose so that they can do something about it. There's also this learning around, it's not just white versus everybody else. There's lots of subtleties in this. We need to sort of unpack this package if we're going to be able to make a difference to the patients in our state. And I just want to share one other. This is one of the new measures. This hasn't been published yet, but I'm excited for this group. A new measure that we have this year is overweight counseling for adolescents. So this, in some ways, I'm not as thrilled about this, because what the group has to do is actually, for identifying patients, you have to actually show in the record that you gave them some kind of counseling. I'd much rather move to an outcome-based measure where you'd ask patients or their families, did you do something about this? But this is an important place to start. And you wouldn't be surprised, this is just a graph that shows in Minnesota, from the data that we have from patients who are being seen, of these adolescents, how many are overweight. And Native American is that first one, very high rates in Minnesota. So the population for Hispanic and for African American and some others are definitely higher, significantly higher than they are for whites. So that's important. So I hate to admit this, but I was so looking forward to coming here and showing you that there was a big gap in the screening rate and the actual outcome rates on this measure for how many kids were getting counseling, and it isn't there. So this is actually quite good news for us. So it looks like all of our other charts, but if you actually look at this closely, because of the confidence intervals, there is no difference between what's happening for African Americans and white as far as the counseling rate. And this is for kids who are actually, this isn't for everybody, so it's not affected by that previous one of the prevalence rate. This is for kids who are overweight. How often are they getting this counseling? And so this is an interesting thing for us to see. This is not, the opportunity for counseling is not the issue. But again, I wonder what would happen if we looked at the outcome for patients by this, and that's the thing that we might want to take a look at next. And this just shows by ethnicity, interesting though, there is a gap, and it's in a positive direction. I think, again, because practitioners know this is a bigger issue for Hispanic or Latino patients, they're actually getting the counseling rate done at a higher rate. It's not probably terribly meaningful, but it is statistically significant in our state that there is a higher rate for that population. And I just, again, wanted to show this. This is African American by medical group. We're brave enough to show this and publish it, if you want to actually look at this. The good news is it's happening quite a lot. You can see in the graph where people are really at a high level of getting this kind of overweight counseling done for patients. I think our opportunity is when you look at the far side of the graph, there are several practices that aren't doing it. And when I pair this, I didn't give you a paired graph. It's not that they're not doing it for African Americans, they're not doing it for anybody as much. And that's the opportunity, I think, when you can show this. There's variation in practices. And part of the reason why, when I talk to people, they don't do this as much, and it's a sad thing, it's the same thing why many practices don't do screening and counseling for patients in mental health, adolescent mental health problems, is because they say, I don't know what to do. I don't have resources locally. This isn't something we do in our practice, so I'm not going to focus on that. And that's a problem we've got to fix, is how do we give practices at this far end of the curve that aren't doing anything the tools that helps them to want to make this happen for the kids, because we know it's so important for their future and for the future of our community. So I want to share a few minutes on what providers are actually doing to try to improve results, because I think this is interesting. Now that we have this data out there, you'll hear that this is actually motivating groups, not just compared to other practices, but because of large groups in Minnesota, they often are trying to motivate different clinicians in different locations within their practices. And this kind of data is very helpful to do that. I'm going to give you some examples about how that happens. But at a high level, what we've learned even from our regular quality measures is regularly reviewing the results makes a difference. And so that's why I want to have this available. That sort of awareness is something that you have to keep at people as far as what the gaps are. Many practices are using electronic record tools to help them get prompts. I think there's great opportunities in the work that we're doing here to try to do more of that. Engaging the entire staff that we heard about before. Often the measures are sort of focused around the clinician in the exam room, but we know for many of these chronic conditions what matters is what happens with the receptionist, what happens with the physical therapist, what happens with the lab technician, and how do you get the entire staff engaged in these improvement efforts and not just leave it up to the doctors who are very, very busy with other things as well. Probably the biggest lesson is that I mentioned earlier, change doesn't happen by everybody working a little bit harder because they're aware of this. So this awareness is really important, but if you say, there's a disparity, go out and work harder and fix it, doesn't make anything happen. You actually have to do that next step, which is, what are the things that we can test that will actually make a difference? So many of our practices are using this data to test what I would call small-scale improvements. If we have the receptionist call back, how does that change? If we change our education materials, how will that change the outcome? And that's really what drives the process here. And then, interestingly, sharing this with patients. I think in the work that we're all doing here related to movement and the challenges of weight and the challenges that it brings to some of the orthopedic areas. I love when I go to meet with practices. One is sharing with their staff. Almost everybody, when you come through the staff waiting room, has some of our measures up on the wall or things that they're particularly working on related to these small-scale improvements. But a few actually post it in their waiting areas. How are they doing? And I'm always surprised because it's not always because they're doing the best. They might just be middle of the pack. But it does change the culture a little bit around, this isn't about just you as one patient, but it makes people kind of feel like they're part of a team, they're part of a system. We all need to work on this stuff, and it takes it out of that I should feel ashamed or bad that I'm not doing well, and hey, this is part of something we're all working on. I don't think that works for every patient, but it probably works for some, and that's why some of the practices are doing that. I'm going to give you some examples of a particular group, Health Partners in our state, that has done, the groups look at this. This is a chart that shows across all of our measures, how are a few of them doing some of the bigger systems, and they pay a lot of attention to, are they above average in as many of the categories as they can get. Internally, though, they turn that into much more detail. So, sorry, this is a busy chart, but I wanted you to see at a practice level, you want to take this information and drill it down. And in fact, in their situation, you'll see on the far right, you can't see the names, but they actually publish internally individual clinicians' results for their patients. And that isn't meant to shame people, but it, again, sort of shows where you're at, what are you doing, and across these different measures. This is an example of that they actually generate the reports too internally on the race and ethnicity and show that with their practices. And this is some run charts that they do internally for different sites. So here's 4 sites that you'll see and how they're performing. The first one on the left is for all the population, and they break it out for public programs, i.e. Medicaid, how are they doing, and then for some of the disparity populations, and set goals within the practice around trying to improve those results over time. And so this is just a list of some of the things that they've been doing to try to reduce disparities. This integrating that component, not just trying to do practice-wide results, but they're reporting internally and setting goals in their accountability programs related to the outcomes for that, making the data available at a clinic level, not just in total for everybody. They have these 90-day work plans that they're doing related to what are some things, interventions that they can do to try to get better outcomes. And interestingly, it was brought up earlier, how do you bring the administration into this? Put it in their incentive plan. And they will actually start looking at how do I partner with the clinicians a little bit better to get these outcomes as well. And so it's added to the physician compensation, but it's the entire team within a practice is held accountable for meeting certain goals to try to improve these results over time. And this can be frustrating. This is very hard work. It doesn't, as I've talked to them, there are many times where you do an intervention and it makes no difference. One of my favorite stories would be an important part, I don't have one on the slides, is actually bring community people in to talk about. So why is it that it's been hard? One of the, to get these results, one example with their practice was they made a big leap in the breast cancer screening because they brought in some Somali women and said, what is the problem? And a lot of it had to do with transportation and time. So they set up a same-day mammography, and boom, the results got much better. They did a similar focus group with African-American immigrant men on why they weren't getting colon cancer screening. They heard about that, they made some changes, didn't change the numbers at all. So sometimes you try things and it works, and sometimes it doesn't. There's still, that still, as you'll see, is in their work plan here that they're focusing on. So very important around having the transparency, but they specifically are working now on a colon cancer screening related to disparities, and are doing a number of different things as far as focused callback, new materials that reach out to specific populations. And imagine, culturally this is hard, again, because so many of the clinicians start from this, and this is another important learning. I treat all my patients the same. I feel bad if I don't do that. And yet, what really works is, you might need to do special outreach for certain populations. You might have to have different materials for them. And that means you've got to identify who you're going to mail them to. And it makes people a little nervous, because I'm being biased, aren't I, by doing things differently? No. Maybe you are being biased, but you're doing something that will get a better result, then that's okay. And that's been, I think, an important change that we have. And again, I won't go into the detail, but one of the learnings for colon cancer screening was don't rely on everyone to get colonoscopy, but do some of the other testing. And that's an interesting question too. Do you focus it on different populations? The key has been offering the things that work for particular populations. It doesn't mean you don't offer the other things as well, but have some focus to it. And finally, I don't want to miss, there's a cultural change that has to go on with this as well. And so they have a newsletter that they're using within the practice that goes out to all of the staff that talks about equity and tells stories. And this is just an example. It sort of has a story of a patient that didn't get screened for a while, and why was that, and what did the clinicians do to get people both aware that these biases are important to deal with, and what can they do internally, but keep it in front of people's in a way that isn't just the data. The data is really important, but it's also the stories that you tell about it that helps to move the culture along. So I want to finish with one thing that is hopeful to me. This used to be an easier story. 3 years ago, what was interesting is in Minnesota, if you looked at in the Kaiser Family Foundation data, the heart disease death rate across the country was monitored, and it was monitored by race. Minnesota was the lowest on the list for everybody, but it was the only state 3 years ago where the African American rate was the same. Everywhere else there was big gaps. Now this has gotten more complicated, so it's not easy, but it's actually a more interesting story that I want to share. So here you can just see the difference between white and black U.S. and Minnesota, and this is obviously be aware it's a worrisome thing to see this nationally, that you have that big a gap in the rates. Also, the hard part of this is not the best metric at one level, because one of the ways to avoid dying of heart disease is to die young, and we do know that's a problem in many of our, but this is age adjusted, so this addresses that a little bit, but it shouldn't be the only metric that we look at. But so this is a very busy graph, but I wanted to share it. So this is every one of the states. This maybe will harken back to what you were watching a couple nights ago as the state results come in. But the results of state by state that in the graph shows white versus black, and I sorted it so highest death rate for African Americans down to lowest. So Minnesota's, yay, we're so proud of ourselves, all the way at the bottom there, and again, there's no disparity. But there's some really interesting things to look at. One is how high it is in some parts of the country, and we know a lot of this does have to do with the things that we're focused on here around movement and other aspects that drive this. But look at Washington, D.C. It's the third one over. White is the lowest in the country. We're actually a little bit lower than Minnesota on that, and African American is the worst. And much of that is driven by socioeconomic factors, we know. But that should be unacceptable to us in this country. But what I'm encouraged by is you go down to the very end of the graph now. Like I said, a few years ago, there wasn't anybody else. There are several states where now, if they're at the low end of the curve, African American, there is no disparity anymore. And again, in most of our data, we don't see that. So I don't want to, oh, we've solved this. But it's interesting, there is this aspect of the more you work on this, the more you focus. There are some things that will drive change, and you can reduce the gaps. And I think that's something we all need to strive for. How do we get this better outcomes for everybody? But we got to get there by focusing on both the equity issues as well as what do we do for the entire population. And a lot of this in heart disease may come from those things I showed earlier. It's systematizing, if you do that related to getting aspirin done, making sure people with diabetes are getting better outcomes, you can make sure that you accomplish that for everybody, but you also need to have some special efforts for your disparity populations. So just some closing thoughts for me is measurement matters. We've seen that just having this kind of data and being brave enough to share it can make a difference. There are very important issues related to risk adjustment that we need to think about, because using this data, we don't want to disadvantage those groups that are focusing on the most challenging populations. But I think what we've learned is you don't do that by risk adjusting away the differences. You still need to show the difference, but you want to make sure your payment policies don't disadvantage those that are having to take the most time and the most effort to get better outcomes for their patients. Need to report the data at a level that it makes a difference. Again, the big thing for us was that we knew about disparities before. There have been many reports for years about Minnesota has some of the biggest disparities out there, but I think we're getting much more traction when we actually report it at a level where somebody can do something about it. And we know clinicians alone are not going to solve the disparity problem, right? But that isn't a reason to say, well, somebody else should fix housing and income and all that, and we'll just wait here. There are things that can be done in medical practices to make a difference. How do we help them do that? Because we should do both. We need to address both as we can. I think it's very important is, while we've looked at race and ethnicity and country of origin, there are a lot of other patient factors that affect disparities that we should be looking at, like housing, that we could bring into this mix. And not because we're going to fix housing, but because practitioners, if they had that information, might be able to work with patients in different ways and get better outcomes for them, and that's what the important part of this process is. So I think opportunities for improving this work that we're doing here together related to physical activity and equity. There's a lot of new data that is going to be available that's coming from Medicare. Yesterday I got to sit next to somebody who was here from the Office of the National Coordinator, and they've been working on this to make sure in this new program around advancing care information that this stuff is available. My message is, it's one thing to collect it, it's another thing to get it used. And so the focus of groups like this that's so important is, how do we get this information used that helps not only clinicians but also communities use it to get better outcomes for their patients. So with that, I will say thank you very much. I'm so glad to get to be here.